the next presentation will be delivered by Dr. Christian GLASER. He is affiliated to, he's a professor of radiology and is affiliated to the Munich University, and he's one of the renowned MSK radiologists from Germany. He will be talking about the ankle impingement.
Thank you, Dr. Rami. Good morning, everybody. Thank you all for having me here. I really feel privileged and happy to have this enormous experience, and I hope I can contribute by reviewing some aspects of ankle impingement. So as in any other joints, impingement relates to pain during movement, and this is due to a conflict between all the tissues in and about the respective joint, be it bony or soft tissues. And there are two components involved. The prominent component is movement. Without movement, there is no conflict. And often in sportive people, this involves abnormal or extreme ranges of movements. So a ballet dancer would maybe have impingement in a morphological situation that a normal person wouldn't experience, because this normal person would not undergo this extreme range of movement. So abnormal or variant morphology, this is our topic as the radiologists, but it comes a bit secondary. So we have sometimes abnormal morphology, but no impingement. And ankle impingement is related either to trauma or repetitive overloading and microtrauma, leading to a secondary process of irritation, inflammation, hypertrophy and fibrosis of the soft tissues, and eventually to bone overgrowth. And this is going into a sort of vicious circle, leading to the patient's pain and limited function. And we have to bear in mind that this is a clinical impingement, is a clinical diagnosis. It is at least a clinical suspicion. And without that clinical suspicion, our imaging findings often are non-specific, so they need that clinical context. So our task, the questions we have to solve is, are there morphological findings supporting the clinical suspicion? If so, which tissues are involved and to which extent? If not, what are the differentials that might reasonably come up? And under this background, we have to look at the osteophytes, ossicles, bony injury, subtle details in CT like erosions, periosteal appositions, in the synchondrosis, for instance, sometimes osteochondral lesions, in order to show what morphology contributes, and as far as the soft tissues are concerned, MRI and ultrasound for inflammatory, hypertrophic, and fibrotic changes. So typically, classically, ankle impingement is addressed by location, like you go clockwise or sextant-wise, and the more frequent occurrences of ankle impingement will be anterior, anterolateral, and posterior, as opposed to anteromedial and posteromedial that tend to be a little rarer. So one typical scenario in anterior impingement would be a soccer player or a dancer going into repeated forced dorsiflexion or repetitive contusion, like in this example, when the ball hits the foot. And that's quite a force that is applied there over and over and over again. So our target area would be the anterior aspect of the tibio-talar joint, and in X-ray we could appreciate subtle osteophytes on both sides of that joint, which become understandable as a potential component in the impingement process when you look at these so-called functional studies, when you do see that there may be impingement. So MRI would show us the soft tissue component with fluid, thickening inflammatory reaction to the anterior capsule, hyperintensity, the fluffy thing, and upon contrast, a vivid contrast uptake. However, we should come up, if we don't find signs of impingement, like here, no bony osteophyte, no predominant inflammatory change, we could and we should come up with the relevant differentials such as anterior tibial tendinopathy or anterior tibial tendon tear, which is frequently not considered in the differentials. So let's move to anterolateral impingement. Our target area here is the area between the lower aspect of the anterior syndesmotic bands, the upper aspect of the LFTA, the anterior of the lateral collateral ligaments, and the space in between. And all of these structures can be affected, again, with that sequence of inflammation, hypertrophy. In anterolateral ankle impingements, it's discussed that too early mobilization after injury may be involved in the etiology of the impingement because of induction of the inflammatory reaction in a stage where the healing process has not been completed sufficiently. So our target area is anterolateral, so the syndesmosis is a good thing to start and then go below. And as in this case, in axial T2 weighted images, you would see that's the lowermost aspect of the syndesmosis. There is a little bit of too much tissue, and because it's squeezed into this triangle between the talus and the fibula, it takes a triangular or meniscoid shape, and then you end up at the upper edge of the LFTA. So contrast, and again, we do give contrast, obviously. In these cases, we'll highlight the inflammatory reaction, even if it's comparatively subtle. And this is what you may encounter in this location. You may have but subtle changes, but the patient has the clinical diagnosis of impingement. This is different from that case where you do see prominent inflammatory change that can be easily appreciated either in the axials or in the coronals by the inflammatory reaction in the corresponding region. If bony components are involved, they usually are accessory ossicles or bony elements after previous injury in the typical location surrounded by the inflammatory reaction, either by contrast or by the diffuse thickening and moderate signal change in the involved ligamentous and capsular structures. Now let's proceed to anteromedial impingement. The pain is anteromedially. Following supination and pronation testing, it's less frequent, but it's considered a separate entity. Involved are the anterior portions in the mostly the deep portions of the deltoid ligament, and when you look at coronals, you do see the diffuse hyperintensity in those T2 weighted images. This is the tibial spring ligament. There you do see the upper portion of the spring ligament. This is the deep portion of the anterior deltoid, and it's thickened and often scarred. And sometimes, this is the axial's post-contrast, you do see the inflammatory reaction, the medial dorsal edge of the talus, the tendons, the ligament, and sometimes you run across, you come across this little bony excrescency, a little osteophyte that the surgeon may want to take out in order to fully eliminate the potential causes of this impingement. This is a differential because anteromedially you don't have so many mechanical structures that can interfere, but in this case, accidentally you may run into a PVNS, and this patient also had presented with impingement syndromes. And of course, in a sports orthopedic setting, you don't think of these entities first. Now let's switch sides and go to the posterior aspect of the ankle. And posterior impingement, it is quite frequent, involves everything between the posterior inferior lip of the tibia down to the dorsal aspect of the calcaneus. And the most common etiology or patients would be the ballet dancer, also the soccer player. And it becomes obvious from this position that and there is a nice X-ray. The space is so narrow that it is easy to understand that there might be some conflict. So our target area is the posterior capsule and its reinforcing elements. The posterior intermalleolar ligament being accused most often for the hypertrophic inflammatory scar-like reaction, but also the bony elements. Even sometimes when you have a deeply downsloping, it's not the case here, posterior tibia, you want to make the relation with impingement as well as with this case of a Stieders process. So this is a case, an example of a soccer player. He's first league soccer player. He couldn't shoot anymore because he had pain posteriorly when he hit the ball. And it was attributed to this very prominent medial tubercle of the posterior process of the talus. The steep, elongated, small, longish lateral tubercle would be here in terms of a Stieda process. But you can have the same effect here. Some people argue this is just a non-separated ostrigonum. And in fact, when you look at your images, sometimes you can find multiple stages that really make you think of the stages of transition between the posterior process, the medial tubercle, fused or non-fused as a ostrigonum. But back to this guy, he was resected, the bone was resected. Don't let you fool by sometimes extensive soft tissue changes post-operatively at this time at 2 months. You wouldn't do that in a normal person, but they tend to get controlled very, very frequently. 5 months after the procedure, he was fine. He could return to full play, and you do see that bony excrescency has gone in the, that's the early post-operative control, of course, in X-ray and not using CT. This is a bit of an unfavorable and not so nice case because a patient 3 months after ankle injury came back with persisting pain, and he was a tough guy. And X-ray as well as CT confirmatory then revealed a previously undetected fracture. And that's a bad situation because his ankle joint is likely to go down the road. If it comes to look at the ostrigonum and posterior impingement, first you have to note its presence, its size, and its relations to the adjacent bones. That can be a bit tricky. What is helpful is the inflammatory reaction in conjunction with the clinical history. And if we look at the axials, we may appreciate, and some papers say so, that contrast uptake or fluid in direct CT arthrograms in the space between the ostrigonum and the parent talus is indicative of or confirmatory for impingement syndrome. In the end, it remains the combination of the soft tissue inflammation, maybe the inflamed state of the synchondrosis, and the clinical history. And there is an interesting finding, it's bone marrow edema pattern around the synchondrosis, which is indicative of a certain mechanical disturbance. There is a disbalanced mechanical load, and that's our interpretation. It is not pain, we can't visualize pain, but it increases your confidence in the appropriate setting that the synchondrosis may be involved in that process. However, the surgeons would always try to do a conservative approach to give the patient a chance to first treat with the inflammatory reaction, and if it appeases, all the better. Now I've included that case into the differentials because in essence it's not true impingement, but it's impingement caused by a bipartite talus. So that's sort of an atavism, non-fused bony center. And here, that previously was the hallmark of CT, show those erosion, these irregularities in that synchondrosis, indicative of the altered biomechanics. So this is our approach to the function. Nowadays, MRI may take part of this information away from CT or may be able to provide similar information by showing the inflammatory reactions, and if you have high enough resolution, also the erosive changes, which would be uncommon in a normal, quiet type of synchondrosis. However, there are true differentials, like Hagelin syndrome with bursitis and Achilles peritendinitis and bone marrow edema in the posterior aspect of the ankle, and they clinically are not always very obvious and clearly to differentiate. Now, don't let you fool with the os trigonum. There's a lot of fluid around this os trigonum. There's hyperintense signal in the interface, implying sort of a loose interface. We know that from os acromiale, but let's be careful. This patient has been operated on Haglund syndrome. It's an early control because he had unusual pain, unusual amounts of pain illustrated here, and 2 months further he was fine. So we have to be careful and really look at the history in order to get our image interpretation right. Now I'd like to end with the posteromedial impingement. It is rare. Our target area is the posterior portion of the deep deltoid ligament, and it's a soft tissue impingement. And there is a classical finding in the clinical history, and this is really helpful. It's true for the other sites of impingement to a certain extent, but it's very typical in posteromedial impingement. And the patient would say, I got my supination injury, I got my anterior tear, the pain went away, but a couple of months the pain came back, and it came back on the medial aspect. And that is a typical constellation that raises the suspicion for posteromedial impingement, that you can appreciate it here to more extent in the axials and coronals. And you see this sharp geographic delineation between the hypertrophic, hypervascular scar tissue and the remainder of the medial collateral ligament. And this is really a telltale sign in these maybe difficult cases to raise the suspicion or to be confirmatory towards the suspicion of posteromedial impingement. Among the more frequent differentials would be the tibialis posterior tendinopathy and posteromedial osteochondral lesions of the talus, of course, that we would have to exclude. So let me conclude. I hope I could show a little bit about the importance of the clinical findings that initiate the suspicion and diagnosis of impingement in the ankle, whether related to trauma or microtrauma. Our task is to look out for bony and soft tissue findings that may be confirmatory towards impingement, or if not, we need to come up with the relevant differentials in order to advance the clinical process. Thank you very much.
Thank you so much for the nice presentation regarding posterior, regarding ankle impingement. Any questions from the audience? Yeah, please.
Thank you so much. Regarding the clinical presentation, usually patients are referred with ankle pain. Sometimes they mention synovitis. And we are puzzled when we see a lot of soft tissue enhancement and fullness within the ankle joint space. In such scenario, if we describe it and we pinpoint to ankle, how would you differentiate if the patient is referred for synovitis and you suspect impingement from radiological point of view and from your conclusion point of view, if there is no clinical suspicion of impingement? Thank you.
Okay. I mean, if the referral is synovitis, that can be general. You would see that mirrored in the images. If rheumatoid disease would be suspected, you would see a generalized arthritis. You would watch out for osteitis, erosions, tenosynovitis, look at the sinus tarsi to really have additional information. Basically, this is similar to that scenario. You go from your first clue, in this case it would be generalized synovitis, and look whether you find something around. Well, it may be a primary arthritis, it may be degeneration. If you don't find that, then it's the topographical location. Let's take that last example of posteromedial impingement. If you find in your axials, and I think contrast is really, really helpful, this sharp demarcation and the typical localization, then you're maybe happy to suggest could be. And that the same is true This is why I highlighted in green our target areas. In those target areas, anterior, anterolateral, for example, you would need to see those findings in order to suggest it. So in essence, in our service, we talk to every patient, not always before the scan, but always after the scan. So what we do is we look whether we have the geographic distribution, and then we question the patient and see whether we go forward. Now, if this is impossible in the respective settings, you can still look at the topographic distribution with the appropriate structures involved, and don't question the patient, but put it in your report, suggesting.
Yeah. Any another question from the audience? May I ask you, okay, one time before, because of the scenario, sometime, you know, there is an old age patient and so on with ankle pain. There was a question regarding impingement due to ostrigonum. And I don't know if you agree with me. And there was an orthopedic consultation, if it's the cause or not. And as you know, sometimes the patient will not describe precisely, I mean, the pattern of pain. So what I have done, I have injected steroid at the ostrigonum, and it was dorsal suet, and it was very minimal amount, and it shows improvement regarding that. It was a striking improvement, and then the orthopedist have done removal of the ostrigonum, and that was solved. I don't know if you agree with this approach in such query cases.
I fully agree. The more clinical we can be, and we have a chance to be, the better. I think surgeons are different from radiologists, and like a trauma surgeon, he would fix a bone, he would put in screws and nails. So he wouldn't want to bother at the first place to frickle around and do a little bit of resection in ostrigonum. He would be grateful for us to give him a confirmed diagnosis, and then he could go on. Why waste his time by frickling around? So I fully agree, even if I do not have the chance to do that every time, or we might not have the chance, but to me, this is the way to go.
Okay. Thank you so much, Dr. Christian, for the nice talk. And it's a pleasure of me.
It's my pleasure to be here. It is truly my pleasure. Thank you very much.
It's really a pleasure of me to introduce Dr. Rami Mansour from Oxford University Hospitals. So to